Good afternoon. We are excited to welcome you all to today's expert roundtable discussing next generation specialty care. This is the 6th event in our quarterly expert roundtable series, following our early discussions on fundraising, diversity, equity, inclusion, product market fit, go-to-market strategies, and building world-class teams. Today, we'll be spending some time with a fantastic group of digital health leaders, executives, and entrepreneurs who have built and partnered with various specialty care solutions. But before I dive in, I wanted to set the stage with some background on the market. Primary care has been an important focus for innovators over the past few decades as the country tries to fix the shortage of primary care docs and rising costs across the system. Companies like Iora, CityBlock, ChinMed have been important disruptors here. Nevertheless, as we move towards risk arrangements, there's a growing need to help manage specialty care, delivery, and costs. In fact, nearly $7 billion was invested in specialty care startups in 2021 alone. Further, navigating to specialty care is complicated. It's expensive, it's cumbersome. So platforms have emerged to help consumers both navigate to the right specialty care at the right time, and employers and health plans are rethinking their offering to proactively, appropriately address specialty care needs and do so in a more longitudinal manner. As we emerge from the pandemic, we have a number of predictions as well as open questions on how to build a specialty care business. And to help shed light on this topic, we brought in the experts to share their perspectives. So today I'm pleased to be joined by 5 outstanding entrepreneurs and leaders. Raj Singh, he's the CEO of Accolade. Accolade provides personalized health benefits solutions to employers. Sam Holliday is the CEO of Oshi Health, a Flare Capital portfolio company, bringing high-quality, comprehensive care to patients suffering from GI conditions. Kristina Saffran is the co-founder and CEO of Quip, a novel eating disorder treatment program delivered in the home. Isabelle Kenyon is the co-founder and CEO of Calibrate, an innovative weight loss business focused on holistic metabolic health. And finally, Dave Guilmette. He's the CEO of Health Solutions at Aon, leading innovation focused on employee health benefits. We will structure the hour into 4 roughly 15-minute fireside chats, starting with Raj. So without further ado, I will hand it over to my partner, Bill Geary, to kick us off with a one-on-one fireside chat with Raj. Bill, welcome to the stage.
Margaret, thank you so much. Appreciate the chance to be here and look forward to having Raj join me. Raj, there you are. Thank you again for being with us. Welcome.
Thank you, Bill. It's great to be here.
Really great having you. Raj, let's just start. Congrats on the fantastic company you've built at Accolade, all the success, all the growth, and the problems you're solving. But maybe just level set for everyone and give us kind of the 2-minute update of the solution offerings of Accolade and what you're targeted at solving for the employers.
Sure. I think you hit the first point really right off the bat there, Bill. We're predominantly focused on employers. We deliver to employers, although we do have a reasonable sized population within TRICARE. For those employers, we deliver a personalized healthcare service. And the idea behind the service is giving every employee and their families a personalized care team. That care team includes frontline care teams that understand their benefits and everything that surrounds those benefits, as well as clinicians, nurses, primary care physicians, and mental health specialists who embed as a team to follow that person through their healthcare journey, ensuring they don't fall through the cracks in many of the places that others in the healthcare journey do. And in turn, for those employers, we deliver better outcomes, lower costs. We tend to lower costs in the first year and then even better on years beyond that, so 4 or 5%, and extraordinary NPS as it relates to the rest of the industry. And so today we're doing that, Bill, for about 600 companies and about 100,000 member population in TRICARE. And that leads us to serving about 10 million people across the country.
That's fantastic. And for those 600 employer customers, what are you hearing with regard to their needs for virtual specialty care?
It's certainly the last 3 years have changed the dialogue more broadly that we're having with employers generally. And there's a new set of conversations that, if you just rewind the tape to 2018, weren't happening. And clearly, as Margaret alluded to in her opening, the beginning of that conversation in 2020 and early 2021 was about primary care, was about behavioral health, and the lack of access to high quality primary care, the lack of access to high quality behavioral health, as well as the burgeoning health equity issues that came along with it. In 2022, I think increasingly companies are saying, okay, we've got a beat on our strategy there. Although I don't think most companies would tell you they've put a pin in the problem and they understand exactly how they're going to solve all the elements of it. I think they've aligned on a strategy. And in the case of Accolade customers, we believe that strategy is Accolade. And they're now beginning to think about what comes next. And without being too long-winded in my answer, Bill, I would say that's come in stages. It came first with how do we augment the primary care physician to make sure they're making the right decision? That was things like e-consults or expert medical opinion. We followed that with how do we ensure that when that primary care physician is sending someone into a network where they don't necessarily have a relationship, that they're getting them to the right care. And in that context, it was less about decision support and more about how can I look at quality, cost, and appropriateness and guide people to the best possible specialist of care in a brick and mortar system. But increasingly now, we're beginning to see the next wave. And I think you're starting to see it in companies like Employer Direct Health or in Carum or others like them who are looking at centers of excellence and centers of excellence driving different specialty care strategies. And alongside of that, for the first time, we're really starting to hear in significant volume, employers looking at virtual care strategies in the specialty care space in tandem with the brick and mortar strategy. I think it's relatively new, Bill. Most of the employers we deal with, we do have some sort of cutting edge employers, but we deal with a lot of Main Street employers. And the idea of virtual specialty care, is, at least in our purview, has been relatively new to them, but it's increasing in its volume and its magnitude in terms of the conversations they're having with us about where they want us to go next.
So the blend of in-person and virtual, of course, is a must. And today it's mostly organized by clinical condition. So as you fast forward, how do you see that evolving? Do you see employers having a dozen different solution offerings based on kind of condition offerings or needs? Or fast forward five or 10 years, where do you see it landing?
I think we're fast forwarding even faster than the 5 or 10 years, Bill. It's very difficult right now for employers. Look, we can debate the rationale for how in the United States we ended up with employers being responsible for figuring out the morass of healthcare for the people that they employ. But it is the way it is. And yet, if you permit me to jump on a soapbox, but I'll get off really fast, these departments are often underfunded, right? You've got a small benefits department that's supposed to figure all of this out on behalf of 10,000 or 20,000 employees and their families. And they're supposed to understand the intricacies of a healthcare system that are extraordinary. And we've seen, though, that those departments or those benefits departments, those HR departments over the last 10 years said, you know what, I'm going to have to wade in because the status quo is not giving me answers that are affordable and high quality. And so what came along with that, and I'm giving you the macro view of this, and then we'll zoom in on specialty care. What came along with that was carve-outs everywhere, carve-outs around condition-specific focus, carve-outs around centers of excellence, around brick and mortar care, carve-outs around particular populations, even if it wasn't specific to a particular condition. And what benefits departments then found was we bought all these things, we've carved them out, they're better answers, there's brilliant innovation in them, but I can't get anyone to use them. And in many respects, that led to companies like Accolade hitting the forefront over the last 5 or 6 years and the adoption in our space. So now we finally get to the answer to your question, Bill. We will see consolidation. It is very difficult for employers to deal with this complexity. They want a single solution woven together. And where that consolidation occurs, or whether that consolidation takes the form of really tight integrated partnerships on open platforms, is an open question. I think I would be surprised if that consolidation occurred and saw value in a carrier-only model. I think it has to happen with some of the disruptors you're going to talk to later today and companies like ours. And I think employers are increasingly leaning into that idea.
So how do you like to work with those disruptors and companies that we're funding and others? And of course, you meet with a lot of innovative entrepreneurs and founders. How do you like to work with those kind of specialist solutions in terms of the offering that you bring?
When we made the choice to enter the primary care space, we acquired a company called PlushCare in 2021. And That PlushCare acquisition actually led really tightly to the Health Reveal acquisition of a Flare company. We made the choice that we wanted to be a quarterback for care, acknowledging that we wouldn't always be the primary care physician, but that we'd have an opportunity to collaborate with other primary care physicians serving our populations. And also made the choice that downstream specialty care was going to be the purview of experts in those categories. And that what we wanted to do was light those capabilities. And now, again, I'll do a quick soapbox, Bill. 6 years ago, when I became the CEO at Accolade, the most frustrating part of this job for me was the inability to share data or the unwillingness of the existing ecosystem to share data in the interest of the patient experience. And so for us moving forward, we want to make absolutely certain, now that we have some mass, that we don't make the same mistakes or propagate the same bad behavior that's existed in the industry before. And so for us, what does that mean? It means choosing partners, building real integration, opening our platform up to say, look, as long as my customer says it's all right for you to have this data, we're quite happy for you to have it. We're going to make it easy. We're going to create APIs for you to get after that data, and we're going to document those APIs. What we want in return is we want some warranty of high quality service for the population we're sending in your direction, number one, and we want the data back so that we can manage that experience. We think that's the way the rest of the world outside of healthcare works: open platforms, sharing data in the interest of the common buyer. And we want to be a beacon in that regard. It's still way too hard to share information in the industry unless there's some sort of overriding economic interest that we think doesn't always yield the best behavior.
That's a pretty open model to partner from your point of view, as well as, of course, to acquire. You mentioned PlushCare and our portfolio company, Health Reveal, 2nd.MD as well. Maybe talk a little bit about 2nd.MD and the capabilities that brought.
It's right along the lines of, Bill, the specialty care dialogue that you're having today. You can acknowledge that the vast preponderance of cost exists in specialty care, and yet oftentimes patients are struggling with what the right alternative is. And if you were to think about our models around affinity to the patient, extraordinarily high NPS, trust, long-lasting relationships, and human touch. We build everything around this idea of human touch. There's plenty of technology behind it, but human touch is essential. We looked at that category and thought, do we need treatment decision support for the patients that we serve? Do we understand the categories upon which most of our patients are seeking our guidance and consulting with our nurses and clinicians on what should I do? So I've just been told I have cancer. They're telling me I need surgery. What's the right answer? That we decided that was a category we had to play in, and that we knew it could drive material value to our patients and drive costs down for employers. And so we looked at the entire category, and what we found there was a company in 2nd.MD that had superlative human touch, meaning while many companies in the category were delivering written consults 2 weeks later, 2nd.MD was acquiring the medical records, summarizing the records, and getting a live physician specialist, one of the top 1,000 docs in the country, on a video call within 3 or 4 days. That made all the difference to us. And that's why we made that deal.
That's great. Raj, what are your thoughts about payment model innovation, specifically taking on the clinical and financial risk above and beyond kind of the solutions that you and others offer today?
Bill, between the public markets and customers and vendors like Accolade or companies like Accolade, the definition of what value-based models is, and whether you look at them positively or negatively, varies by those prisms. In our view, though, at the end of this story, we have a value orientation. Here's what we mean by value. We should base our fees, and we should base everything that we generate from the employer who we're serving on, are we improving clinical outcomes? It's one of the most exciting parts of the business moving forward, is us looking at customers and saying, we're going to improve your A1C levels. We're going to improve the blood pressure readings. We're going to actually warrant that value. We're going to warrant that your costs are going to come down, and we're going to warrant that we drive extraordinary engagement and a high NPS. And if we don't deliver those things, we shouldn't get paid. That to us is how we define value. I think when you think about value orientation in other industries, there can be some gamesmanship involved. And I think in the last 6, 9, 12 months, there's been some variability in terms of delivery of some of the folks who've been out there in the value-based care model. To us, methodically pushing employers in that direction works because we believe in it. And we think employers, when they understand it, will flock to it.
Super insightful. Can't tell you how much we appreciate you being with us. We're proud to be shareholders in Accolade and wish you much success, and obviously here to help you in any way we can. But thank you so much for being with us today. We really appreciate it. My
pleasure, Bill. I really appreciate you having me.
Thanks again, Raj. We'll see you soon. And now I'm pleased to turn it back over to Margaret and Parth, two of my Fleur Capital colleagues, as they welcome to the stage our next panelists, Kristina, as well as from Equip, as well as the CEO of Oshi. So Margaret, over to you.
Thanks, Bill, and good to see you, Parth. We'll give Sam and Kristina a second to join us. Hey, Sam.
Hey, how are you? Glad to be here.
Doing well. Hey, Kristina.
Good to see you. Great to be here.
Awesome. This is truly our treat. We understand that you two are good friends, so Parth and I are really honored to be up here with you guys today. But thanks again for making the time. Maybe just to kick us off, so you both have such interesting backgrounds and are building super important companies in our space that are bringing care to millions of people. Maybe just to kick it off, would love to hear a little bit about your journey and what inspired you to build these companies. Maybe Sam, we can kick it off. I would love to hear from you.
Sure, happy to. Hi, Kristina. Good to see you. So for me, I was working in diabetes, and I did that for a number of years. And we saw the impact when you connect clinicians who are experts in helping on a particular condition with patients through technology, telehealth. But what I saw happening in diabetes was things like Virta Health, using food as an intervention. On Duo, building an entirely virtual clinic that could prescribe, diagnose, de-prescribe. All of that collided with my family experience. My mom getting diagnosed with irritable bowel syndrome, learning about a food-based intervention, figuring that out, blowing her gastroenterologist's mind because she actually figured it out when most people don't off the one-page handout. And then as we dug into it, realizing she also had psychological triggers for her symptoms. And as we dove into it, realized, wow, there's all this gold standard evidence of what works to help people like my mom. But as you look around in the healthcare system, it's not the care we typically provide. And so really the inspiration was digging in and saying, would a business model like a Virta or an Onduo help solve this problem for the millions of people with GI issues? So that was the inspiration.
And my story is pretty similar based on my own personal experience. So I was diagnosed with anorexia when I was 10 years old and struggled throughout my adolescence. After spending my entire freshman year of high school in and out of hospitals, I was really fortunate to have access to family-based treatment, which is the leading and only evidence-based treatment for eating disorders, which really recognizes that eating disorders are brain disorders and at a high level takes the healthy people in the household to structure the home environment for pro-health behaviors. That was my road to recovery, but in recovery, learned that 80% of the 30 million Americans with eating disorders don't get treatment, and said, got to do something about this. And it's in my life's mission ever since. And so it first started a nonprofit, Project Heal, originally to raise money for people who couldn't afford treatment, and was really fortunate to grow up learning about this field with some of the leading academics and clinicians in the field. And the thing that really struck me, interestingly, I started Project Heal in 2008, the same year that the Mental Health Parity Act was passed. And while it's a phenomenal law, Patrick and Amy Kennedy, great advisors to Equip, the unintended consequence was that private equity entered the market, and the eating disorder treatment landscape looks really similar to the substance use treatment landscape today, with lots of private equity money going into residentials and rehab facilities. And starting this little scholarship program at 15, I started to see people applying to us with access to $45,000 a month of residential care and no quality outpatient care. And that just made no sense to me at all. And so essentially, after working in this system, I started to say we need to partner with payers instead of treating them as the enemy and the devil. If we're talking about access for all people, we need to be working with them. And so about 3 years ago, sat down with a number of executives from top health plans and basically talked about, how do we build a better model of outpatient care? You guys are spending a lot of money on care that doesn't work very well, and there's good quality outpatient treatment, but it's incredibly inaccessible. What gives? How do we do better? And they essentially said, if you build it, we will come. And we were off to the races.
Thank you both. Extremely powerful stories, and appreciate you both sharing a little bit more about your journeys to date. Jumping in and diving a little bit deeper in your model, one of the first questions we'd love to get both of your perspectives on is measuring outcomes of virtual first models. Both GI and eating disorders have historically been treated in physical settings. I think we're all super curious to hear how you've designed your virtual clinical models to maintain and even improve upon clinical outcomes, and what critical elements of your models unlock this. So maybe we'll start first with Sam and then move over to Kristina.
Sure. I think one of the key differences when it comes to outcomes in GI, again, I worked in diabetes. You can prick your finger at home, very low cost, highly accessible, and you get a number, and that number tells you how you're doing. And the interventions are pretty similar across people with diabetes to improve that number. When we looked at GI, we realized there aren't those easy biomarkers, right? It's about tracking your bowel movements. It's about your abdominal pain, your constipation. It's more symptom reporting. The current care system really doesn't track these things. And if they do, they're asking you to retrospectively remember the last 3 to 6 months or keep a paper log. And so I think digital capabilities are really positioned to help measure this stuff more frequently. But at the same time, we really haven't put any incentive in place for providers to ask the patient, have your symptoms improved? And do you know how to keep them there? So in some of the clinical studies that have been done in the GI space for drug development, for example, they'll use symptom improvement and symptom control measures that are tailored to IBS, to IBD, but these aren't really in clinical practice. And so we looked at that and said, those are really important leading indicators. And what if we could tie improvement in symptoms and control of symptoms, meaning I, as the person suffering, know what to do to keep my symptoms down, to cost and to the reduction in cost. And so that's really a big part of how we are thinking about measuring our model. And we're doing it, and we're running a clinical study now and seeing amazing outcomes on all the things that matter. Satisfaction. 80% of our members that come in say they were neutral to dissatisfied with trying to access fee-for-service GI care. 80% say it didn't solve their problem. And we really flipped that on its head, 98% satisfaction and 85% plus saying we actually got them to symptom control, taught them how to learn the tools to stay there. And now we're also seeing real impact on total cost of care as well. So I'll pause and let Kristina go as well.
Yeah, unfortunately, in mental health, kind of broadly, there's been a huge lack of measuring outcomes. And my co-founder and I talk a lot about how dangerous this is, because in mental health especially, I think there's a big difference between treatment that feels good and treatment that works. And unfortunately, a lot of the treatments that work are really hard. They don't feel very good. It's much easier to go to somebody, a therapist who's warm and empathetic and a good listener, but that's not going to get you better from your PTSD. It's not going to get you better from your eating disorder or your OCD, unfortunately. And unfortunately, you blame yourself as the patient when you don't get better from one of these symptoms, instead of looking at the treatment provider and blaming them. And so it was really important to us from the very beginning. We talked to payers about you have a right to be asking for outcomes from the providers that you reimburse. And more importantly, the providers need to be measuring outcomes because they need to be continually looking at what's working and tweaking the model to make sure that we're seeing continuous improvement. And so all of that is to say, outcomes collection is incredibly important to us. We look at, it's interesting because the eating disorder field broadly has done very little of this. In a residential facility, they're essentially asking, did you have fun in treatment? Would you recommend it to a friend? So we think that's really unacceptable. We look at a couple of different measures when we think about eating disorder recovery. One is symptoms and behaviors like binging and purging, restricting. We're lucky in eating disorders in that we do have a pretty clear biomarker that is weight. In a residential facility, the kind of gold standard is gaining a pound a week. We've been able to consistently put on 2 pounds a week in the first 8 weeks for our patients on weight restoration and 1 pound a week thereafter. We're also looking at quality of life improvement. This is really important. It's not enough to just be abstinent from behaviors, but really looking at, are you having success in building that life worth living? And then finally, for us, we know that parental self-efficacy and confidence in being able to care for their loved one with an eating disorder at home is actually the strongest predictor of how quick your recovery will be and how lasting your recovery will be. So that's an important metric for us as well to look at. One of the things that's been really exciting for us in this fully virtual model, we started this before the pandemic, and we were always going to build 100% virtually because access was really our North Star. But 2 years into seeing families, we strongly believe that virtual first is the right approach for eating disorders. And it's really for two main reasons that I talk about. The first is this idea that you can't build a life worth living if you're not living life. Certainly, I've seen so many peers of mine who I've been in residential treatment with 15 years ago who are still cycling in and out of facility-based care and haven't graduated high school, graduated college, held a job, held a relationship. It's so much harder to get into recovery then. But even when I was 10 and going to 4 different appointments a week, I couldn't be in soccer, I couldn't be in theater. I didn't have the ability to really build up reasons to drown out my eating disorder. And then the other thing that we're seeing is that this virtual format really allows families to bring their entire village into care. We have families bringing mom and dad and aunt and babysitter and grandma. And again, this is a hard treatment, and it works better when you can tag in your entire village in a way that brick and mortar just really wouldn't allow. And so we've been really excited to see that the virtual format not only maintains these strong outcomes, but actually makes them even better.
Very well said, Kristina. Maybe sticking with that for a moment, member engagement is such a critical component of driving outcomes, right? How have you and the Equip team thought about developing a member engagement strategy, and how do you work with your peer partners to enable this?
Yeah, it's a fantastic question. So right now we get our members in a number of different ways, from direct to consumer channels to providers, pediatricians, inpatient hospitals, to actual payer case managers referring the members themselves. I think we know that the best patient engagement strategy is certainly coming from providers who see these patients in the clinic. Before I founded Equip, myself and my co-founder had worked with thousands of pediatricians, adolescent medicine specialists who essentially said to us, like, I don't screen for eating disorders because I don't have anywhere to send people. It's a black box and I don't want to open it when I don't have any resource for them. And so really providing this service to them to say, we're going to help you to easily identify eating disorders. We're going to give you a script, so how to talk to the family about it, and then a really easy referral channel into Equip. We also know that I think in everything, peers are a huge part of our treatment model. So we are big believers in the peer-to-peer approach. Peer-to-peer, doctor to doctor has certainly been one of the strongest strategies we found. So one of the things that we did really early on was recruit a phenomenal adolescent medicine physician, Catherine Hill from Stanford, who had worked in eating disorders for the last 10 years, and she serves as our VP of Medical Affairs. And so she's really going out again with this peer-to-peer approach, understanding adolescent medicine physicians, understanding her physician peers, and really is able to speak to them in the language that they know, understands the constraints that they have, and has really helped us to think about what is the best outreach strategy for us.
That's awesome, Kristina. And Sam, I'm very curious to get your perspective there as well, and perhaps even given your relationships with employers and how you think about both engaging with employees at the employer, but also just generally just differentiating and really kind of see solutions that are available to employers today. I'm curious if there's any messaging that seems to really resonate with those partners.
Yeah, and Raj alluded to it in terms of the employers are overwhelmed by the number of solutions coming at them. And one of the things that we think about a lot is how do we make it very easy for them? How do we actually take the work off their plate to contract with us? And the simplest way is to get covered as an in-network option for our care delivery. And Kristina mentioned the payer. We're engaging the payers to say, build us into the network, and then going to the employers and saying, hey, this is about leveraging your platform to help connect us to your people, to let them know this is a different option for GI care. One that could be a better experience, generate better outcomes, maybe save cost for you as the patient, certainly for the employer who's covering it. But really, I think the other part about the engagement and outreach strategy, GI conditions happen throughout the year, right? So saying we're going to just promote this during open enrollment that may not be the time that someone's symptoms start to escalate. So we have to have ongoing outreach and awareness campaigns. But I think this is also we haven't really talked about care navigation, but great partnerships there and with the virtual first primary care entities that are popping up, whether they're carrier-led or the Accolades of the world, or we partner with Firefly Health as well, so that we can get those direct referrals like Kristina was saying, whether it's someone reaching to a care navigator saying, hey, I need help, where should I go? Or it's through a virtual primary care. So I think those are some of the approaches we're taking to make it simpler for the employers to really leverage their ecosystem and benefits.
Yes, super interesting, Sam. And maybe even along those lines, we've talked a little bit about the virtual models here, and just curious, as we think about kind of the traditional tech stack and how you've had to evolve that tech stack to meet the needs of these virtual models. Curious lessons learned from that process, anything that keeps you up at night as you've thought about building out the tech stack and evolving it as well.
We started building a couple of years ago, and I think the good news for entrepreneurs coming after us is that a lot of companies have popped up saying, hey, most of the EMRs out there aren't API forward. They weren't really built for a workflow of a virtual provider, but they're now our option. We unfortunately didn't have those options at the time we started building. So we are on some of the EMRs that are more legacy, and we've stitched together the experience to make it as seamless for our clinician as possible and to make sure as much of that data can flow, for example, from the EMR with our care plan into the app so the member can see it and track against it. So those are the kinds of integrations we've had to build between the different parts of our stack.
Yeah, and I would just briefly add, don't try to reinvent the wheel on things that are not unique to your business. We're not going to try to reinvent video or chat, right? There are great platforms for doing it, but really looking at what is unique to our model. We have this 5-person care team that needs to collaborate with one another, with the family. So it's often 10 people in a collaboration. And that's the thing that we work on to build specifically for our population.
Awesome. And last question here. I know we're running up on time, and so would love a quick reaction from you guys, but it's a super important question that we want to ask all of our panelists. You're both building first-in-kind models that maybe didn't have a previously associated reimbursement paradigm. I'm very curious what comes first, or what came first for you both. Was it the payer reimbursement, or did you need to prove member outcomes and experience before you could unlock that?
I guess I'll start. We felt like we needed to prove the outcomes. And I think this is true with Kristina as well. There had been clinical trials proving the fundamental approaches we're using. We had to show, hey, if we translate this into a virtual first format, we can actually do even better in many cases than these trials and scale access. And so we started there, and we're now leveraging that to go gain reimbursement. And I'll say, the problem we're solving exists because of fee for service, not reimbursing the dietary and psychological interventions. And there is no way for us to get paid in fee for service. So we are moving into more value-based approaches to reimbursement.
Yeah. And we were, I think, really fortunate to build these partnerships with payers from the beginning. Again, this, if you build it, we will come. And Optum kind of came to us and said, we're gonna start with you. And we know that we need to do this in a value-based framework that really puts patient outcomes at the center. And have been fortunate that we've had a number of strong early adopters where we work in a real partnership framework to be sharing data concurrently with them as we build.
Awesome, guys. I know we're on time, but really appreciate you both sharing your wisdom and thoughts with us today. And would love to continue the conversation. I think we need to pass it over now to Dan, who'll be joined by Isabelle on the stage. I really appreciate your time today, and thanks again.
Thank you.
Dan, I will pass it over to you. Give you a couple minutes to get up here.
Thanks, Margaret. Really appreciate it. Sam, Kristina, great accounts. Excited to bring Isabelle Kenyon to the stage. And I think in that last panel, it just reminded me there was such powerful personal accounts. It really is the privilege and the responsibility we have as healthcare entrepreneurs, investors, operators. It's not just about building a business, but really changing lives and impacting populations. So excited to have you here with us, Isabelle, on the heels of a very successful $100 million Series B raise for your business, Calibrate. And before we dive into the business itself, would love for you to introduce yourself to our audience. I've had the pleasure of hearing you speak before, and talk a little bit about the origin story and how you came to found Calibrate.
Thank you guys so much for having me, and thanks for letting me listen to such amazing speakers today. I think you'll hear a lot of overlap and a lot of the same themes here, but I'm Isabelle. I'm the founder and CEO of Calibrate. I started my career in investment banking. A smart recruiter called me and told me I'd prefer startups, move it over to startups, and broke my back and pelvis skiing, and was my first real interaction with the healthcare system. And like many on this panel, vowed to spend the rest of my life fixing the healthcare system because it seemed fundamentally like one large retail business that should be an e-commerce business. And that is the right amount of naivete to have entering the healthcare business, because otherwise you'd never do it. And during the early team at Capsule, the pharmacy startup based in New York, learned the ins and outs of the flow of funds across the healthcare system, across payers, doctors, providers, consumers, and pharma companies, and was really just like mind blown and following very closely. What did the wraparound mean? What did beyond the pill mean? How was pharma going to improve the efficacy of drugs in a increasingly not fee-for-service world, and an increasingly competitive world, and in a world where we have increasingly better data. And so pharma was literally knocking on the door of our windowless pharmacy in New York, being like, you got to help. And I was like, there's something here, there's a category that this will be really interesting in. My mom had a doctor's appointment and learned that she needed to lose weight to get back in control of her health. And she didn't tell me, she didn't tell anyone. She called different bariatric surgeons. She asked to have bariatric surgery. They said she didn't qualify. And then she called and she said, I'm really frustrated. I don't understand how this is a medical problem without a medical solution. If my weight is a medical issue, how come there's not a medical solution? I've diet and exercised my entire life and it doesn't work anymore. And you have to help me find a doctor who can help me. And I did. Turns out every fancy academic research center in the country has an obesity board certified doctor who has known for close to 3 decades that the right way to treat obesity is to improve the patient's underlying metabolic health, which is measurable. And that sets them up for long-term sustained weight loss of 10 to 20%. And I just could not believe that we've known this for decades and we don't make it available, and that it's fee for service, and that this doctor wanted my mom back in her office every 3 months for the rest of her life. And I was like, this is not what the research shows. Like, the research really clearly demonstrates that if you do this for a set amount of time, 52 to 68 weeks, like, you can drive real long-term results and outcomes. And just started digging the research, started contacting the doctors who'd published the research, saying like, why doesn't this happen in the real world? And they said people would never pay for it. I'm like, I got people who would pay for it. And I think what I was talking about last time we talked is what an interesting inflection point this is because of that, right? Because consumers are paying for their healthcare. That gives you like this wildly different opportunity than you had 10 years ago to go out and prove, like Kristina's been doing, like I've been doing at Calibrate, that there is consumer demand for something at the same time that you build your payer business, and at the same time that you fundamentally expand access, you get to prove outcomes. And I think that's a really unique moment in time, and very excited to be building Calibrate now.
Yeah, no, excellent landscape there. When you talk a little bit about kind of customer acquisition, you've entered the weight loss market, right? Which I think has been for a long time a very consumer-driven business. A lot of big brands with a lot of consumer awareness. How did you think about diving into this market? What surprised you, or what was easier than you thought in acquiring consumers with the Calibrate brand?
Conventional weight loss doesn't work because what we tell consumers to do doesn't work. And so those businesses work when their sales and marketing teams work. And I said from day one at Calibrate, I want to build a business that works because the product works. And if this product works, consumers will pay for it, their employers will pay for it, the government will pay for it. And those are really the only 3 people you need to convince to pay for healthcare in the US. And so it felt really obvious to me that the way to break through here and the way to win was to have a product that worked. The catch-22 on that is like, how do you prove that your product works when no one's used it? And so what I always say that is, when we entered the market, we didn't have product market fit, we had market fit. This market is so fundamentally broken that there was a cohort of consumers who would try the next thing without a single review on the internet, without anyone saying that they had done the program before. And that's really lucky. And I'm not sure how many markets like that there are, but that was the case for us in this market. And it let us go out and get the first 1,000 customers who we published the results on in January, and let us go prove that it works. And that's led to the next 20,000 customers who learned about it from friends and family. And that is really compelling here. And I think gives you a sense of the fact that maybe we have found product market fit at this point, but ultimately, like, it was really market fit in the beginning.
I like that. I like that. Free product, you knew you had market fit. You had a lot of tailwinds, which I think is super powerful, right? When there are no great solutions for consumers, there's just a big opportunity. And to your point, sometimes they'll be forgiving as you continue to evolve your solution.
And we leaned into that, right? Like, our first members, we called our early access members, and we asked for feedback, and we discounted the program for them. And we really made it reciprocal in terms of help us help you.
Yeah, no, so true. Maybe switch gears for a bit. Your business started out direct to consumer. really engaging with consumers, having them pay out of pocket. How do you think about the legacy healthcare system, existing primary care providers, existing health systems? Does Calibrate interact with those organizations? Do you need to? Do you not need to? How do you think about that?
Absolutely. I want to just correct one thing there, which is that everyone in the US pays for their healthcare out of pocket, like through taxes, through deductibles, it's like these are wages or it's healthcare. Like it's a zero sum, right? And so I think at the end of the day, like when people say the consumerization of healthcare is because of high deductibles, I'm like, seems like an interesting contributor, but like at the end of the day, we'd all be getting paid more if our employers weren't paying for our healthcare, right? And so I think that's always been true and doesn't seem like a paradigm shift to me. What we say we did at Calibrate was decouple acquisition from payment, right? And so we went out and found customers and we got them to pay for the cost of Calibrate, which is $1,500, but we also got their employers to pay for the cost of the medication, which on a net basis is between $3,000 and $10,000 a year, depending how well you negotiate with your PBM. And that is really important because from the get-go, we were actually getting payers to pay for the program with consumer demand, with consumers moving their feet and choosing. And I think that is something I just got so excited about, I forgot your question.
No, it's excellent. And again, I think that's super powerful. And just thinking about it from the consumer's perspective, what are they paying for out of pocket? What will their employer cover? And then trying to subsidize or at least reduce the cost and reduce the activation barrier. My specific question was, are you interacting with other providers, other primary care providers, other health systems that may have cared for this patient prior?
One of the things we've been really clear on since the beginning is that we want Calibrate to ultimately be a platform for chronic disease management, and that we think that there isn't a good platform that combines med management with wraparound lifestyle intervention, and that's powerful and needed in the world for a variety of chronic conditions. That said, we were pretty honest with ourselves and we've held really true to this idea that you can only be good at one thing at a time. And we need to just prove that we're good at this. And so today, all we do is treat obesity. And if you need your diabetes medication titrated, if you learn that you have a heart condition, if you learn something else from us and our doctors who are doing lab work and intake work with you, you will be referred out to a specialist, you will be referred back to your primary care, and we will work with them to make sure that they are signed off on your care and treatment. And it actually has turned into, probably like Kristina, an amazing referral channel for us. Because when primary care doctors see the progress that their patients are making, they end up recommending and referring Calibrate to other patients. And we saw this last year. We've been asking new members who referred them to Calibrate since the beginning, and we saw that jump to almost 10% in Q1 of this year from basically zero at the end of last year. But as those first members hit 1 year, started going back to doctor's appointments, their doctors. So I would say today we are structurally sending data back, letting doctors know that patients have been diagnosed with new conditions and letting them know about the medication that we're using. We send them a one-page letter about the Calibrate program so that they can reach out if they have any questions or want to understand more, but we do not take on care for other chronic conditions today. And that generally makes it like a pretty non-threatening addition, right? There are very few doctors, exactly 5,000 of them, that could view us as competitive. And that I think puts you in a really nice spot too.
Yeah, no, super powerful kind of virtuous cycle that you just described. And again, I think I'm a former physician myself. Doctors are rational creatures. And so to your point, you have to really think about how will the doctor view our business? Will they see it as a threat? Will they see it as complementary? Like, super insightful. You talked a little bit about getting coverage from employers, from insurance. How do you think about making that leap, as it were, from just acquiring consumers and having them pay out of pocket to actually having the burden of proof to get enterprises to cover? How did you think about that?
I think two things. One, we've demonstrated that we're good at acquiring and activating customers, right? Like today we're getting customers to pay $1,500 and the average household income is $75,000. So we are like really getting people who like look like the employees of the employers in the US. And I think that's compelling and interesting and like demonstrates that you've got a special ability to activate a customer, which is I think what most of employers like fatigue around point solutions feels is like, how am I going to activate another point solution? Like, how am I going to help people understand like when to use A or B? And if the value prop is clear enough that people are signing up themselves and understand like true identifiable value that's been proven in the market for it, I think that gives payers and benefit managers and benefit leaders peace of mind that people actually attribute value and we actually know how to do that. The second thing is we've driven outcomes and we've published them. And we didn't publish on like the 500 people we wanted to publish on. We published on the first 800 and 40 people who entered the program, every single one of them. What happened? What was the completion rate to 6 months? What was the completion rate to 12 months? How much weight did they lose? Did they track their weight loss or not? Like, we published the N on every single metric in that report. We had all of our clinical advisors review and work through the report with us. And so I think the idea that like we went out and published all of our results, something Weight Watchers has never done 60 years later, is completely insane to most doctors. And like you said, they're rational. And whether those clinicians are working in private practice or working at a health plan, making decisions around care protocols, I think same appreciation for the fact that outcomes have been our North Star since day one, and we're not afraid to publish and share them, and we're committed to doing it on an ongoing basis.
Super powerful, Isabelle. You talked a little bit about engagement and activation of customers, which is something these enterprises strive for and haven't really been able to do. And then also outcomes. I think I loved how you described the other existing weight loss companies are really marketing companies, but you are really focused on being a healthcare company and driving true outcomes. Super helpful. Isabelle, I think we are at time. Sorry to cut the conversation short, but thank you so much for joining us.
Thanks for having me.
Now I'll transition over to my partner, Michael Greeley, who'll be interviewing Dave Guilmette. Michael?
Hey, thanks, Dan, so much. I'm delighted to welcome Dave to the stage. Dave is CEO of Aon's Health Solutions business and is a good friend of the firm. Actually has worked closely with two of my partners, Chris Hosevar and Ian Chang. So Dave, welcome. I couldn't think of a better person to close on, given your sense of voice of the customer. And we've heard a lot about novel solutions coming to the market. But before we get to that, you've had a long career in and around the employer space, Willis Towers, you're obviously now at Aon. But let me give you a chance just to briefly introduce yourself, and then I have a couple of specific questions.
Sure. Thank you, Michael. And it's truly a pleasure and an honor to be with you in this distinguished panel, really impressive entrepreneurs and folks who are making a difference in healthcare. So thank you for the opportunity. I've been around a while, a long time in the space, and I've seen it evolve quite a bit. The vast majority of that time was on the advisory side in the consulting businesses, Towers Perrin prior to my current role at Aon, with about a decade in between on the supply side with Cigna in a variety of capacities. That's where Chris and I got a chance to work together and did some work in actually helping to stand up the Cigna Ventures entity, which started to invest directly in various startups and did quite a lot in the innovation space. Always been passionate about health and well-being of populations, right? Workforces and the like. And here at Aon, I have an opportunity to really bring some of that experience and help to lead our team to try to make a difference for all the employers we serve of all different sizes. So very large, jumbo, sophisticated companies, the who's who that we always read about, and lots of what we would think of as more middle market, right? So companies with several thousand employees who don't have the staff oftentimes or the sophistication that the really big jumbos have, but have the same challenges on a global scale. So I'm having a lot of fun with it. We have a lot of work to do.
Yeah, terrific. And Dave, given that, maybe comment about the state of the market segmentation. We heard a lot of interesting novel solutions in the last 45 minutes. How does the market, you think, shake out?
So it's interesting. I was listening to Raj when he opened, and I thought, my goodness, either he looked at my notes or I looked at his notes. But maybe the takeaway is two relatively informed individuals with similar perspectives on the market. The headline I think I would lead with is, I think employers of all sizes who have been working with various point solutions are experiencing a version of point solution fatigue. When we look at the relationships that a typical large employer has that we serve, and it may not be a surprise to you, but it was a little bit of a surprise to me that on average, they manage 22 individual relationships in the benefits space when you think about various carriers and various point solutions. And to the points that were made earlier, they don't have the capacity for that. You know, the HR functions have been downsized over the years, and it's a lot to manage each of those relationships, never mind actually having them work in sync as a true supply chain. So I think one of the really important themes that we're picking up and that we're helping our clients with is that the supply chain actually isn't a chain. It's a bunch of disparate suppliers. And so how do you put together a true system, whether it's 3 or 5 or the entirety of what is on point to deliver benefits and healthcare support to employees and their families? And so really starting with shared accountability for what you're really looking to accomplish. In our point of view on this is, look, it may be perfectly rational and reasonable to expect a quote unquote vendor, a solution provider, to meet your expectations on their piece of the equation, right? So what are they, performance standards, call them what you will. But if one part of the system meets or exceeds expectations and another part of the system fails, the entirety fails.
Yeah. So
right?
Dave, will the market forces, does that imply there'll be some aggregation around certain populations? How does that play out over the next couple of years? And what's your specific advice to entrepreneurs? Isabelle was very articulate about point solution fatigue. What's your advice to the entrepreneurs on the webinar about how to navigate that?
Yeah, the right question to be asking. I don't think that the market is looking to move back to the mean or reversion to the mean, or maybe put differently, that we're going to buy everything from a vertically integrated provider.
So your clients that have 22 on average solutions, that'll continue, do you think? Or will that naturally aggregate?
It'll consolidate, but it will consolidate in clusters. And the first step in that equation will be, let's really start to isolate, what's the problem we're trying to solve? We're trying to deliver a better experience, better outcomes in oncology, in a different type of specialty. Is it an access to primary care challenge that we're facing? Is it a mental health challenge that we're facing? A lot of our clients right now are really worried about workforce resilience all around the world. So they're really starting to double click on, what do I need to do as an employer to be able to either rebuild that resilience or retain it, because something else is coming our way, as we've experienced over the last couple of years. So really understanding what the pieces are, how they work independently, and then how can they be put together, and we can help shape that. Now, outside of that, if we look at the entity on its own, and there were some examples that were raised today, leaning in on how can the point solution better integrate with existing players in the marketplace. Doesn't mean they have to be rolled up under them. And Accolade's a good example of how that entity came together. And it's not end-to-end for everything, and it still needs a strong relationship with provider networks and payers who are actually adjudicating or evaluating whether there's medical necessity. Those things have to work really well together. But I love what I heard from a couple of them saying, we're going to the Optums of the world or the Cignas of the world, and we're saying, we think we have something of value, include us, right? Let us be part of your solution.
Interesting pricing. Where does that fall as you're advising clients or in your clients' buying decisions? How do they think about pricing of these solutions? Is it high on the right? Is it high on the stack of issues?
It's high. I think it has. We're starting to hear, and I think this is being fueled a lot by the quote unquote great resignation or the other challenges we're seeing in terms of just the employment dynamics these days. They're turning their attention to more towards value and experience, and what is it doing to enhance my benefit portfolio or make my employees' lives easier, right, in some fashion. But it doesn't mean they're taking their eye off the ball on cost. The ideal equation is I can check that box and I can deliver that experience, and the cost for that specific solution is relatively small. If you start to put pieces together and you're getting into larger PEPM type numbers, then they're going to pay a lot of attention, and they're going to want to really see the outcomes, and they're going to want to see the proof points to be able to say, go forward.
We're almost at time, and we could have done this for an hour, but can you comment just on the relative white space in the virtual care market right now? Where is it overpopulated? Where do you think there's still opportunity that's quite emerging?
I wouldn't call it overpopulated. I would say it's crowded in certain areas of sort of specialty solutions. Where the opportunity exists, and it was alluded to earlier today, is to connect it up with virtual primary care, virtual specialty care, home-based therapies where you're actually using technology to care for individuals and monitor those individuals, because we saw the challenges associated with the supply chain for healthcare delivery in the US over the last couple of years, and that's not going away. So I think the white space is going to be much more around the front end, right, of primary care, and ultimately putting together complete packages. So if I need to see somebody, that's the second thing I do. The first thing I do is interact with the benefit on a virtual basis.
Got it. Hey, listen, Dave, that was terrific. I'm sure people would love to follow up with you, but I'm really grateful for your support and engagement, and really thank you for your time. With that, I'm going to excuse the two of us and let Margaret finish us up. Thank you, Dave.
Thank you.
Thanks, Michael. So as we close today's session, I want to thank all of our guests for their time and insightful advice. We covered a lot of ground, but obviously there's still a lot more to talk about. So as always, please reach out if you'd like to continue the conversation. Thanks again for joining. Take care.